My name is Jackie Sable, and I'm a member of the ECHO team. I'll be facilitating today's session. A few announcements before we begin. If you've not already done so, please put your name, email address, and affiliation in the chat box for our record-keeping purposes. Please stay muted unless you're speaking, but feel free to unmute if you have questions or comments, and you can also use the chat for communicating. We realize that Q&A time is very important, and we do try to categorize and address. I'm sorry, someone just said they can't hear me. Is everyone hearing me?
I hear you.
Okay. All right. Thank you. Sorry for that. So if you have questions that are not answered during today's session, please submit them as a possible case for a future session. The link that we send a link out with the case submission. So please feel free to submit things if they don't get addressed today, but we do try to monitor the chat and make sure that whatever questions are coming in are addressed. Please remember that during any of our case discussions that no personally identifiable information is allowed. We do record these sessions, and we will share the recording and any materials after the session. In the spirit of all teach, all learn, we'll be on a first name basis during our sessions. For those of you who are not familiar with ECHO, our ECHO sessions always begin with a brief lecture, followed by a case discussion. And cases, again, could be a question, a challenge, anything that you want to address that could be related to patient care, to preparedness, policy, whatever challenges you're facing through the COVID-19 crisis. So we encourage you to submit those cases. For today's session, we do not have a case, but Dr. Lauren Van Scoy, who will be giving the brief lecture on ICU care, she does have some case information to share for additional discussion purposes. So again, please feel free to put your questions in the chat if you have any during the lecture. I will be monitoring that and sharing them with Lauren as we're going through. We have a team of specialists from Penn State who join as they're able, and they'll help field questions as well. But remember, this is all teach, all learn, so anyone can post both questions and answers. And with that, I am going to turn things over to Lauren for our brief lecture, and she'll be controlling her slides herself.
Okay. Thanks, Jackie. So thank you, everybody, for logging in. This ECHO is meant to focus on intensive care in COVID-19 patients. So as you may know, Hershey has some ICU cases. We are still learning as we go, as is the entire world. And so what I've done to prepare today is tried to assemble resources that sort of encompass the general principles and some data to support some of the principles and put aside some of the, hopefully, some of the myths. These are the key articles. I'm sure when they send out the slides, these are the ones that I really focused on for this presentation. So if you have questions about the data that I'm going to talk about, this is where you can find it. So the first thing I wanted to mention is that I wasn't sure exactly who the audience would be, and I know that a lot of folks may have questions about how we get patients to the intensive care unit here at Penn State. And so we have the emergency room and an ID triage team looking at all of the suspected cases and letting us know if they think that they are low risk or high risk. If they are low risk, they're put on regular droplet precautions, and the high risk patients are being put in the negative pressure rooms. And this is changing hourly. It may be different now than when I put this presentation together, in that new recommendations were saying that only patients with aerosolized particles may need negative pressure rooms. And so I'm not sure where it's fallen with that. We're working really hard to minimize staff exposures. So we conduct history by phone if able and appropriate. As of yesterday, when I made this bullet, trainees were not allowed to be in physical contact with suspected or COVID patients, although now our fellows are going to be going and taking care of these patients. We have something called TURF teams, which are the teams that are caring for our potential COVID, so undifferentiated respiratory failure. And we have all of our ICU patients cohorted in various sections of the hospital. The SICU, which is our surgical ICU, for our ICU patients, and in the emergency room, they have cohorted into one area of our emergency room. And they are working on surge plans for using operating rooms for various surging if we need more intensive care beds. Currently, there is no routine family visitation, although there is circumstances in which are being evaluated case by case, and those conversations are dynamic and changing as well. So when a patient is coming to the ICU, what's important to remember is that we have to remember that even in COVID-19 patients, we need to be providing our patients usual care. And so this is something that we've been working really hard to remind ourselves. So usual care would mean triaging for the ICU. If you have a patient who has some hypoxia and you're thinking that they may need an ICU, we get the call, and we try to make our triaging decisions based on usual and standard care. We do have a lower threshold for upgrading patients, particularly if they have high oxygen requirements, patients that we may have put in a step-down unit before. If we are suspicious that they're COVID patients, I have a lower threshold for putting them in the ICU based on literature. Similarly, for transfers into our facility, we are in a catchment area, and so the way that we're managing our transfers is when we get calls about potential COVID cases, we accept patients with COVID into our ICU as the ICU team. However, we do have a higher threshold for managing those patients at local hospitals. So sometimes, we'll do a transfer, only if there's a service that can be offered here at Hershey or at a tertiary center that can't be managed at the outside center. And what can be managed comfortably is often a judgment call. And so in this situation where space in a tertiary facility is so scarce perhaps, or will be scarce in the future, we're having a slightly higher threshold for what we bring in from local hospitals. But we are trying to bring in all of our patients to make sure that all patients get standard of care. And in those triage decisions, we also have to think about, if you utilize a chopper, then the chopper goes out of service for 5 hours because it needs to be contaminated and clean. So there's a lot of new issues that we're learning and slogging through as we're accepting our transfers. The system is rationing PPE to healthcare providers, as most systems are. And I wanted to call attention to the fact that only 20 to 30% of the hospitalized patients are requiring ICU. There's sort of some misnomers out there, at least in my family, that if you come into the hospital with COVID, you're going to end up in the ICU, and that's not necessarily the case. So I'm collecting data from the various sources, and I want to just put in a word of caution about the emerging data from the various hotspots. Every place has a different local structure, different testing and screening. And so the Chinese experience is different than the Italian experience, which is different than the New York experience, and so on. And so what we've been trying to do as we're developing policies is think about the Hershey experience, of which we don't have very much. We're drawing upon the experience of our colleagues dealing with COVID around the world, but also noting that the denominators are constantly changing. And so there is emerging data that the Italian experience may be different than the Chinese experience. And I think that's important to keep in mind. And so in my opinion, it's really too soon to make definitive statements, and that this is something that's going to take years to sort out. And so we're kind of doing the best we can with the information we have, and doing what we think works. So my advice is to use common sense and stick with the basics. So what seems to be very clear from all of the literature is that the risk factors for ICU requirement for patients that are COVID positive are things like older age, multiple comorbidities, and patients that present with dyspnea and anorexia, or nausea and abdominal pain. Patients with high SOFA scores, for those of you that aren't familiar with the SOFA score is a severity scoring of patients with organ failure or septic shock. And that's a score that's been utilized in research to show that, of course, the higher your SOFA score, the more likely you are to come to the ICU. There are some studies suggesting gender differences make a difference, that men are more susceptible to needing ICU than females. And then there are other studies that do not find this association. And one of the reasons is, again, the whole concept of local context. One of the studies that showed that males were more likely to come to the ICU had to do with the fact that they were primarily the seafood market workers that had the original exposure. So this study was published in JAMA by Dr. Wang, and it was a retrospective study of 138 patients, looking at what types of symptoms they had. So if you're a hospitalist and thinking about upgrading your patient to the intensive care unit, who are the patients you should be more suspicious of that they're going to sort of crash and burn and need an ICU? All of the patients in the ICU had fever, and we think this is because of the cytokine storm that's being seen in the patients that go into ARDS, or acute respiratory distress syndrome. Fatigue was another one. 81% of the patients had fatigue. The dry cough was almost 60%. Anorexia was statistically different in the 36 ICU patients versus the 102 non-ICU patients. So they were more likely to have anorexia and similarly dyspnea. The onset for this particular cohort in China was a median of 8 days from the time they were coming into the hospital to ending up in the ICU, and similarly, that's about when they developed their ARDS. And those median days are actually shorter in some other studies. The lab abnormalities of the patients that end up in intensive care unit, it's pretty consistent what folks are finding. The low lymphocytes, the LDH, hepatic injury, kidney injury, and the elevated PT or the coagulation cascade abnormalities. And what they found is that the patients that ended up in the ICU that were non-survivors had sort of this, usually it's a lymphocytic predominance, but once you get into that cytokine storm, then the neutrophils start to rise. We see markers like D-dimer, urea creatinine, and the lymphocytes start to go down. And so that's sort of been something that's been reported in the patients that are the sickest and in the ICU. Ferritin is another one that's been trending. So I put these numbers here. This is from the cohort, 2 cohorts in China. This is Dr. Wang's cohort, and this is from the Wu paper. Both of them were JAMA or JAMA-IM. And you can see the values here. So these patients are not mounting big white counts. Their D-dimers in the, these are the patients in the ICU were in the 400s. The LDHs were in the 400s, and they had a mild bump in their LFTs. And it wasn't in the hundreds, it was in the 30s, 40s, 50s. And so I think just getting an idea of the severity of the numbers can be helpful when you're trying to figure out, where your patient sort of lies. In the other cohort, they were following these labs, and you can see the percentages here. I'm not going to read them all, but I think LDH being elevated is a big one that was consistent and significantly different in the ICU patients versus the non-ICU patients. So once they got into the ICU, what happened? So 30% in the Wu study ended up needing a non-invasive ventilation like high flow oxygen, and only 2.5% required invasive ventilation. That was pretty similar in the Chinese experience, although what we're hearing out of New York and out of Italy is a different picture, that there are more intubated patients. So again, I think that the context and the local cultures may be different. And in fact, the CDC, when you look at the CDC website, the range of people that received invasive ventilation was ranging anywhere from 47 to 71%. So I think these numbers are just constantly changing, and you can see there's these big swooping differences. And it seems to be that this is a more accurate picture. So the clinical syndromes that ICU patients have are things, of course, ARDS, acute respiratory distress syndrome, arrhythmia, sepsis, and shock. In our experience, which is not reported in the literature, but in our 3 patients, we've noted that they go into renal failure quite quickly. And that is something that could just be the fact that we have an N of 3, but that's something we're seeing locally. The minority of patients in the literature, like I said, required intubation. Here's more, this is more about which patients not just come to the ICU, but which patients actually develop ARDS. So fever, cough, productive cough in some, dyspnea, and here are some combinations. Most of this is not going to really change the way that you treat the patients, but it's just sort of, I think, useful to take a look at. And then I have some information about the chest x-rays, and I'm going to show you some CAT scans in a little bit about most of these patients, if not all of them, or the vast majority, have bilateral infiltrates and comorbidities. So the time from admission to ARDS in the ICU is only 2 days. So they kind of develop ARDS quickly. The patients that are more likely to go into overt ARDS are the older patients and the ones with a higher fever, and the ones that present with the initial symptom of dyspnea. So if you see these patients in the emergency room and you're sort of wondering, you know, should I send this one to the unit or will they be okay in a step-down unit? These are the risk factors that put them at higher risk, and I would put them in the intensive care unit. Similarly with the comorbidities. There were some studies that showed that the antiviral treatments were reducing the risk of ARDS, although I believe that there was a study that showed something different than that. So I think the jury's still out on that issue. Okay, so imaging. So the chest x-ray, most of them are bilateral. They all have something on their chest x-ray. Of course, that's part of the diagnosis of ARDS. CAT scans are currently not advised, although they are quite helpful diagnostically because the COVID positive pneumonias do look quite characteristic. The reason we don't recommend CAT scans is that it contaminates the CAT scanner and moves the patient throughout the hospital. So we're trying to avoid that by getting a portable scanner because the scans are actually effective in helping make the diagnosis and helping us to assess treatment. But when you think about the public health risk of taking that CAT scanner out of commission, we are not doing that. On the CAT scans, the thing that's really characteristic is that these are ground glass opacities, and I'm going to show you some photos, but they're peripheral, and we also see a lot of crazy paving. And so those are the three main ones. And I want to just give a shout out to Dr. Frank Skierba from UPMC who allowed us to use these slides. He was with us recently and shared some photos of COVID patients from China, which I believe is where he got these from. So thank you for sharing these. So you can see here, so this is quite different than a lot of the regular pneumonias that we see, particularly in ARDS. You can see these sort of round peripheral lesions with this ground glass fuzziness. Ground glass, for those of you that aren't familiar looking at CAT scans, it's sort of like a sugar coating appearance. It looks like someone sprinkled sugar on top of the black parenchyma, which is normal. You can see these are sort of like round lesions, just unusual and a little bit different than most viral pneumonias that we see, which most viral pneumonias are atypical in their spread and they sort of are patchy and diffuse. And this can certainly be that way, but these are the more characteristics. This is interesting because this is, again, a more typical pattern of a viral pneumonia, but it's quite peripheral. So this is sort of classic. Pointing to these thickened linear lines here and some of these reverse halo effects. Oh dear, someone's knocking on my door and ringing my doorbell. Okay, the joys of working from home. And again, here is another area of these loculated lesions, and this has some of these air bronchograms around it, these sort of signet rings. Here's a more consolidated pneumonia. This is going to be distracting, and here are some of the crazy paving where you can see these thickened interlobular lines with a ground glass center. So this is the reverse halo sign. Again, a peripheral lesion, not diffuse across the entire parenchyma. Bronchoscopy. So bronchoscopy is actually very helpful in making the diagnosis because the virus is more likely to be detected in the lower respiratory secretions. However, it's a very high risk procedure for aerosolization. And so we are not routinely performing bronchoscopy in COVID patients. If a bronchoscopy were to be needed, we're using our interventional pulmonary colleagues to do so. Even though we all bronch routinely, these are extremely high-risk patients, and we're only doing it if absolutely necessary, and we've yet to find a circumstance that it's been necessary. I hope you can't hear my doorbell. Okay, the bronchial mucosa, hyperemia, and swelling is what you see on the airways, and there's some jelly-like sputum. So the treatment. This is the biggie. So, you know, again, stick with the basics. So early intubation is really important. One of the early questions about COVID was, Do we intubate these patients in the ER? Do we move them to the ICU? Do we try them on BiPAP? And I think that the profound consensus in this is no, you intubate these patients early, and that you intubate them early to avoid aerosol generation. Because the non-invasive BiPAP machine can aerosolize these issues.
Thanks.
I'm giving a talk to 200 people. Sorry, that was my husband. Sorry about that. He was locked out and ringing my doorbell. Okay, back to early intubation to avoid early aerosol generation. We try to keep it in a controlled setting with direct visualization, so that we're using a glyoscope. We're doing it in the emergency room. We're trying to be proactive and early and controlled in our intubations. And we've noticed that after we intubate, patients become hypotensive and bradycardic pretty quickly thereafter. So we try to do all of the lines and A lines as quickly as possible using experienced providers for the intubation. We do try, most of these patients will end up, on 2 liters and then 4 liters and then a little high flow. The recommendations from SCCM are to give it a shot at high flow for just 1 to 2 hours, so much shorter than we would do normally. And then if they aren't responding in that period of time, then to intubate them, or if their PF ratio is less than 150, which would suggest severe ARDS. The standard is, of course, just like any ARDS, is to use low tidal volume ventilation with 4 to 6 cc's per kilo. And high PEEP has been controversial in ARDS, but in COVID ARDS, it has been actually found in the literature to be quite effective, and in our experience as well. These patients require high levels of PEEP. We're trying to use plateaus less than 30, driving pressure less than 15. Of course, that's the standard ARDS guidelines, and using sedatives, sedation, and conservative fluid management strategies to help achieve those goals. Sedating and paralyzing, when we do have issues with oxygenation, increasing the sedation as much as you can and or paralyzing is needed to reduce that oxygen demand. And so these patients who are profoundly hypoxemic, we need to use high levels of sedation for that. Prone positioning is being used in all of our moderate to severe ARDS patients, with the prone position being in place for 12 to 16 hours. And then we can start thinking about flipping them back onto their back when the PF ratio goes above 150 for a prolonged period, like 4 hours. And so that is sort of our standard. ECMO is available at our center. We've not yet used ECMO, and I think the guidelines and the recommendations for ECMO seem to be changing. Coinfection. So one of the big things in ARDS is treating for bacterial secondary infection is almost always recommended in any ARDS, but it seems to be particularly important with COVID patients. And so anyone with septic shock and COVID, even though it's a viral pneumonia, we are treating broadly with antibiotics. We are using ceftriaxone and doxy for community-acquired, and vancomycin and zosyn for hospital or nosocomial-acquired. Co-infection with influenza is rare in the literature, although our first case of COVID, we had a co-infection. So the patient was positive for influenza and ended up also being positive for COVID, which was somewhat surprising to us in the beginning, although he was treated as if a COVID the whole time. So my rule there, my caution there is to make sure that the patients with influenza or other viral infections are still considered for COVID, because it's not clear rates of co-infection. The other thing in the guidelines, and to my knowledge, we've not seen this yet, but fungal infection, looking for aspergillus, thinking about galactomannan testing for fungal infection, and coverage with caspofungin is also sort of mainstay of treatment. So when things are going badly, and the way that these patients are presenting is with sensitive hypoxia. So they're obviously quite hypoxic. They seem to be responsive to PEEP, but these patients sort of have this downward trend. And so we may get to the point, to my knowledge, the patients have not yet required this, but today's a new day, so I don't know what happened today. But ECMO is, of course, a consideration. 3 to 12% of the COVID patients on ECMO or of the COVID patients have been on ECMO. I got that from the CDC. And then epoprostenol or Flolan are recommended as salvage therapies to help improve the oxygenation. Recruitment maneuvers were originally not recommended, although I did see yesterday that there were some guidelines suggesting stepwise recruitment maneuvers on the ventilator. That's when you increase the pressure and the tidal volumes for a prolonged period of time and then bring them back down. And so it's not entirely clear to me whether recruitment maneuvers are or are not helpful. At Hershey, we are part of a clinical trial where we are, there's a double-armed or a double-blinded placebo-controlled trial of the antiviral remdesivir. We have treated a patient with the IL-6 antibody. For those that have high IL-6 levels and the cytokine storm, that is sort of a case-by-case basis. We are using hydroxychloroquine in all of our severe end-stage or severe ARDS patients. And we were originally using azithromycin to help with the anti-inflammatory effects, but stopped using that routinely because all of the patients we tried on it had prolonged QTCs. And so now that's case-by-case basis as well. So the word on remdesivir, it was reported to have in vitro activity against the virus that causes COVID. There was a New England Journal article that I read the cliff notes showing that it was not an effective trial. And again, we are participating in more clinical trials. I think it's too soon to know. And there is compassionate use being used for pregnant patients who are not on pressors. So the other one that I think is important for the community hospitals in particular is steroids, because that's something everybody sort of has access to, hopefully. And so the dosing would be Solu-Medrol 40q12. And there's some data to suggest that this is a helpful therapy, which steroids has been debated for decades. Use it, don't use it in ARDS. Right now, the field is in a don't use it state. But in COVID, it seems that because of the cytokine storming in particular, there's maybe some benefit to steroids. The CDC does not recommend the use of steroids as of a couple days ago, the last time I checked. But there is some data that shows that for the patients that had severe disease, high fevers, the ground glass opacities, and rapidly progressive, that steroids were beneficial in that cohort of patients. And so that's something you can consider. Again, the Wang article from China showed that half the patients got the steroids and they didn't see any effects. And the Wu article showed that some of the patients did have a positive effect. So it reduced the risk of death. And so again, I don't know that we know for sure. If I had to make a guess, I would say that steroids probably are not helpful, just basing on the extensive ARDS literature in steroids, but nobody knows much about COVID, so who knows? And again, as of yesterday, it was not recommended by the CDC. So what happens to these patients? I feel that this is really important because knowing what happens to our patients can help you to counsel family members and also in policy development about, how do we treat these patients? Do we perform resuscitation? What's the prognosis? And I'm going to speak only from the Chinese experience because I haven't yet seen the data from Italy or other more local areas. But a quarter of them were requiring ICU care. 34%, that's pretty good, were discharged from the ICU. 4.3% died and 62% had remained hospitalized at the time of that publication. The CDC had reported that there was a 2.3% case fatality rate in China, but that mortality rate is likely biased upwards, so it may be even lower in our local context. In the Wu study, it was a higher death rate, so here it was 4.3%, and in the Wu study it was 22%. And you can see 72% of these patients were discharged. So I think it's important to just keep in mind some of the sensationalized media may not be reporting factually, I guess. Okay, outcomes for the intubated patients. Well, the patients that got intubated in the WU study, only 66% of them died. Not only, that's 2/3 of them, but 21% were discharged. And so the patients who are intubated, that does not necessarily mean that you're approaching futile care by any means. Although in the ZOO study of 32 patients, all but one of them died. And so the variability in these measures obviously is what makes me very cautious to make generalizations or policies based on these kinds of data. So I will stop there and see if there are questions. I do have a case presentation, a hypothetical case presentation, but rather than do that, maybe I should stop for questions.
If there are questions, please feel free to unmute your microphone or go ahead and put them into the chat box.
Ooh, I was so clear.
So I don't see any questions just yet. So why don't you go through the case, and if questions come in, I'll let you know.
Sounds good. Okay, so this was a hypothetical case, actually.
Can you hold on one second? A question just came into the chat. Jennifer says you mentioned
a glide.
it?
Yeah, sorry, I'm using lingo. Thanks for calling me out on that. A glidoscope is a direct visualization. So when we're intubating the patients, we're not using direct laryngoscopy where you use that little thingy that you stick up, so you're getting your face right in there. Instead, we're using a video-directed camera so that we can see the vocal cords and place the tube that way. And so sometimes when we intubate patients normally, we just use direct laryngoscopy and only use the glidoscope if it's a risky airway or a concern. But these were the anesthesiologists who are intubating these patients, or the ER physicians who are intubating these patients, are going straight to the glidoscope. Sure. Thanks for the question, Jeff. Okay, so this was, I pulled this case from, it was like a drill we were in, and it was the case that, similar case anyway to one of the drill cases, so I thought it would be relevant to bring it up. So this was a 45-year-old male with saturations in the 70% on 6 liters in the emergency room. And so our pagers went off and they said, here he is, and he's in the emergency room with a blood pressure of 100/50. And the question was, how should this patient's hypoxia be managed? So additional information, obviously this is a COVID talk and it was a COVID drill. So this was a patient who was highly suspicious for COVID with positive contacts and flu-like symptoms and fever for several days prior to presentation. He had some nausea and decreased appetite and no other past medical history. And so the issue that arose here was, this is a patient who's on 6 liters of nasal cannula. We can get him, he's quite hypoxic and short of breath. How do we manage this? Do we up titrate the nasal cannula? Do we go to a BiPAP or a CPAP? Do we do a high flow nasal cannula, or do we intubate? And in this patient, I think you could make an argument to try a high flow nasal cannula for 1 to 2 hours. To see if there's any improvement in the saturations that persists. But if you try the high flow nasal cannula and the saturations are still on the lower side, obviously then you need to move straight to early intubation. And the lesson in these cases is that we want to make sure that we're intubating these patients early and in a controlled way. So you can use the high flow to sort of stabilize, but at the same time, you should have your airway team on standby so that they can prep the meds. They can do everything they need to do outside the room because these are the patients that are more likely to get intubated, particularly because this patient had the fever and the decreased appetite, which are sort of the risk factors, additional risk factors for this patient ending up in the ICU with ARDS. That is all I have.
So are there questions or comments about the case or the lecture at this point?
Are you taking all questions?
Yes.
So my name is Terry Washington. Thank you for the presentation. I'm wondering if you have any experience guiding families and patients through the decision-making process. So, for instance, if the person of a patient might be needing conservation and they're concerned about long-term ventilation and quality of life, and they have a DNR, they're afraid of ventilation, what advice are you giving them about the statistics of their recovery and what we're seeing with long-term disability once they get
It's really hard for me to hear you. I heard you in the very beginning, but then you sort of like tracked away. Did anyone hear that could repeat the question?
No, could you?
Yeah, let me say it again. So the question is related to how you're counseling family members and patients in relation to the need for intubation and ventilation. So, you know, what the odds are based on the other parameters you're seeing for their recovery. And I think particularly for older people that have DNRs or have that concern about what is their quality of life going to look like after recovery if they've been on ventilation.
Yeah, I don't think that the COVID status really changes the way that I would approach those families. I mean, obviously, a patient who is elderly, who is having hypoxic respiratory failure and needs to be intubated, there's a very high likelihood that those patients are going to have a major change in their quality of life. And I generally will talk about things like, you know, even if we can get through this acute phase, which it's possible that we can, you know, we still have to deal with the deconditioning and the trauma from the experience and the likelihood that this patient's going to need prolonged care, perhaps even in a nursing home. I try not to get too, in regular ARDS, I should say, we try not to get too far down the path, but it's also really important to paint that picture up front so that the families kind of are making informed decisions about the direction of care, as opposed to just thinking about this one particular moment in time. We can intubate them right now and get that oxygenation up, but then what does it look like downstream? And sometimes it's too hard to predict that early on. And that's when we need to use our experience as intensivists, I suppose, to say, you know, these are the patients that these are the characteristics of patients that do well. These are the characteristics of patients that do less well. And I would personally avoid using numbers or prognoses because it's just for COVID patients, because it is so unknown as to what the truth is, and the numbers are so fluctuant in the literature. Obviously, if you've got multiple organs failing and if the patients are, you know, refractory, hypoxic, and, you know, that can push you over to, you know, recommending DNR, recommending DNI strongly. You can, you know, I would strongly recommend DNR, DNI in those patients, but I'm very careful not to rely on emerging numbers that seem to be changing. So I try to use broad brush strokes, if that makes sense. Does that answer your question?
I'd like to add one thing real quick. This is Andy Perbolis. I think Lauren's point is very well taken. I think the other thing we're trying to encourage people to do as they're seeing these patients is, if they are still awake and able to give you some information, making sure you're helping them think about who their surrogate would be, especially if you have concerns about them getting critically ill rapidly, so that, you know, the team going forward really knows who to be talking to if their situation changes or they become delirious, because I think there's also a fair amount of these patients who we would expect to either develop delirium or be sedated to the point where they can't really make their own medical decisions.
Yeah, that's a great point, Andy. Thank you.
How do you answer to, and what I'm seeing is there, you know, in the news and all that stuff about with the DNRs, DNIs, people responding or thinking that hospitals are having that conversation more than usual because of the COVID and the issue with possibly not enough ventilators. I don't know if you guys have come across that or heard anything, or how you might speak to the public concern that healthcare decisions are being made differently than they had previously in regard to intubation and ventilators?
Yeah, that's a great question. And that's like question 1, 2, and 3 from everyone who hears I'm an intensivist. They ask me about our resources and do you have masks and what's going on with the ventilators. And I think, you know, like I said, every local context is different. Obviously, yesterday, the American Thoracic Society put out a call for intensivists to, you know, drop everything and go to New York to help with care there. And so I think that what's going on in New York, I am not privy to, I don't really know. I can speak to what's going on here in our area in central Pennsylvania is that are not shortages currently, that we are providing standard of care to everyone, taking additional precautions and risks, or not risks, but trying to reduce risks. So if a patient would normally be a resuscitation candidate, then it's not something, we're not making unilateral DNRs just on the status of, on the basis of whether or not they have COVID. We're really looking at medically treating patients as if they had COVID or non-COVID respiratory failure. And so I think that what I would counsel folks is, you know, we're prepared. There are surge plans. There are contingency plans. People are talking about things and making policies. I believe in JAMA, they are going to be releasing an allocation, a scarce resource allocation policy that is being released by Doug White and his colleagues. And we were able to review early, and those plans are in place should we need them, and hopefully we won't ever need them. In our area right now, resources have not been scarce, and so in the absence of scarce resource, I'm also on the ethics consult service, and I do a lot of ethics. So from the ethics, wearing my ethics hat, what I would say is that we shouldn't be changing the way we treat patients on a hypothetical resource issue, that we need to treat our patients based on the local context that's happening right now, and that leadership and policies are being made to change the way those things are happening should that be needed.
Just want to add, this is Andy Probolis again, adding one thing to that. At the same time, we also want to be sure that we're talking to people about what their preferences are, and making sure that we're advocating for them to get the best care given their circumstances. And I don't think that's really changed in the midst of this, but it's certainly something that we should be talking to people, especially folks who are older and at higher risk, about what they want and what they don't want, in the absence of, as Lauren said, a surge situation or a crisis situation.
Yeah, absolutely. Having those early goals of care conversations, are part of standard of care. And so that's what I would try to tell people is that, maybe we're made more aware of it now. So it seems like it's happening more prevalently, which unfortunately may be the case, but that's something that should have been happening all along. And so that's considered standard of care.
LJ, there are a few questions in the chat. The first one is, any experience with patients self-prone while on NC?
No, I've not heard of that. In general, the recommendations for proning are for patients with moderate to severe ARDS. So I'm not sure that there's ever been any studies of patients on nasal cannula and self-proning. I don't know physiologically if that would really make a difference or not, but if they're comfy on their tummy, why not?
And then another question is for bedside clinicians providing care to a COVID-19 patient. What is an exposure and how are you monitoring them?
Oh, I don't know if I'm the right person to answer that. I can say in the ICU, what I've been told by our leaders is that based on the Italian experience, the PPE is adequate for adequate PPE does protect you from COVID infection. COVID infection is much like tuberculosis. It's the same biosafety level, and we use the same protective equipment as tuberculosis. And so I, remind myself of that. And I know that there's a lot of challenges with COVID living on surfaces, and that's how it's transmitted. But my understanding is that with adequate PPE, there should not be problems with healthcare providers contracting it. Now, that's not to say PPE can't fail or become scarce, or someone doesn't don or doff by the book and something gets put on a door handle. So I'm not to say that there's no risk, but That's my understanding. And I know you guys have had a lot of echoes, and maybe others want to comment about what the hospital has been doing for screening of healthcare workers.
Hi, this is Karen Kroc from Hershey. Could I address that for a second as well, too? So I think there's some, obviously there's a lot of concern because even before this outbreak started, people were coming to clinics with respiratory symptoms. And so there is some good data out there that spending about 15 minutes or so with a patient is when you start developing a higher risk of contracting the virus. And so for right now, what we're doing, if there is, one of the best ways to control the spread of this is having those contact, figuring out the contacts for the patient. But if you are, feel like you've come in contact, for sure, check with your own employee health, because there might be some specific guidelines at your own institution. What our institution is recommending is that those providers wear a mask at all times then, and to check their temperature twice a day. And if they have any symptoms, to then be notified, to notify employee health again. But I would also suggest checking with your own employee health. Again, remembering it's about 15 minutes at least of exposure where you run the risk, and to make sure that you're checking your temperature.
So are there any other questions or comments, either comments around exposures and monitoring, or other questions in general? We very much appreciate you taking the time to come here today, and we won't sit online for 13 more minutes for the sake of making this an hour. But I do want to mention, if you do have a question, go ahead and pop it into the chat right now, and I'll just give a few quick final announcements before we wrap up. Remember, you're able to collect CMEs for participating. If interested, please complete the survey that comes out after this session. And if you participate in multiple sessions, please do one survey for each session. It's always the same link. We will be sharing all materials, including links to our YouTube channel, where we have all of these recordings stored. And finally, we hope you will join us for our next echo session, which will be tomorrow, Saturday morning at 9 a.m. And Dr. McGregor Skinner will be back to discuss home algorithms. And please watch your email, because we are already getting next week's schedule ready to share.